Good afternoon, colleagues. My name is Hannah Simonds. I'm a clinical oncologist from Stellenbosch University in South Africa. I'd like to thank the organisers for the invitation to speak this afternoon. I'm presenting two studies today, both on PARP inhibitors. The first is an NRG oncology group study, which is a phase 3 of single-agent Olaparib versus the combination of Cediranib and Olaparib versus standard platinum-based chemotherapy in recurrent platinum-sensitive ovarian carcinoma. The study was mostly undertaken in US sites. So there is some evidence that there is synergy between a TKI and a PARP inhibitor, and that is the basis of this study. In addition, the investigators wanted to consider whether oral non-platinum therapy may be an option for ovarian cancer patients who have relapsed following 6 months or more than 6 months after their initial ovarian cancer treatment with carboplatin paclitaxel. The reasoning behind this is to try to avoid the risks of rechallenge, which include platinum allergy and exacerbation of neuropathy with a taxane. And there has been some evidence that the combination of the TKI and PARP inhibitor showed progression-free survival benefit in a phase 2 study. The study design is, as I've said, greater than 6 months after initial platinum-based chemotherapy. Patients were tested for BRCA and stratified versus mutant versus wild type. Study drugs received was platinum-based chemotherapy followed by observation, or a standard dose PARP inhibitor Olaparib to progression, or a combination of Cediranib and a lower dose Olaparib to progression. The primary endpoint was progression-free survival. Patient characteristics were evenly balanced. Of note for us here in Africa that the inclusion of Black or African American women was less than 5%. About 25% were BRCA mutant positive. So the primary endpoint of progression-free survival showed no significant difference between the groups, with a median PFS for chemo of 10.3 months, 10.4 months for Cediranib and a PARP inhibitor, and 8.2 months for a PARP inhibitor alone. Overall survival was also no difference, with a median overall survival on average of about 30 months for all three groups. The response rate was highest in the chemotherapy arm at 71% and reduced for the PARP inhibitor alone arm. BRCA mutated patients showed a higher overall response if they received a PARP inhibitor or a PARP inhibitor with a TKI. Those that were BRCA negative showed a highest overall response rate if they had a chemotherapy, if they were randomized to the chemotherapy arm, with an overall response rate of 72%. They assessed the progression-free survival difference after removing patients that had crossed over from chemotherapy to a PARP inhibitor, and there remained no difference with median progression-free survival between the chemotherapy or Cediranib and Olaparib arm, with the PARP inhibitor arm with the lowest median progression-free survival. Adverse events in all three groups included hematological toxicities, and in the patients that received Olaparib, they were more likely to have GIT toxicity, and the patients that received the PARP inhibitor and the TKI showed an increase in hypertension. Adverse events were even over the chemotherapy and combination arm and lowest in the PARP inhibitor arm. So this was the first study that compared oral non-platinum regimens to platinum-based IV chemotherapy in platinum-sensitive ovarian carcinoma. The combination arm did not improve progression-free survival, but was probably comparable in clinical activity. However, patients with a germline BRCA mutation in the arms that received a PARP inhibitor alone or a TKI-PARP combination showed substantial activity over and above chemotherapy. So non-platinum therapies may be an alternative for women with recurrent platinum-sensitive ovarian cancer, particularly if they have a BRCA mutation. However, in our setting here in Africa, that's a real challenge. Firstly, the costs of BRCA testing is very high, and access to these drugs due to cost inhibitions and import difficulties make it unaffordable for the majority of the patients. The second study was the final overall survival analysis of SOLO2, or the ENGOT study, which was performed in multiple centers across the world, European-based mainly. And this was a phase 3 study looking at maintenance Olaparib in patients who had platinum-sensitive relapsed ovarian cancer and were BRCA positive. So the background is that relapsed ovarian cancer has a very short time to relapse after each successive line of treatment, and the goal is to try to reduce symptomatic disease progression and try to delay the need for subsequent chemotherapy. So the study design was relapsed high-grade serous or endometrioid ovarian carcinoma, patients who were BRCA mutated and had received at least 2 previous lines of platinum-based chemotherapy, and they were randomized to receive Olaparib alone versus placebo. The final analysis of overall survival showed a median survival of 12.9 months in the PARP inhibitor arm over placebo, despite 38% of placebo patients receiving a PARP inhibitor on progression. They then adjusted the placebo group to exclude those who had received a PARP inhibitor and found that a median overall survival of a PARP inhibitor over placebo alone improved to 16.3 months with a hazard ratio of 0.56, and this was significant. The time to subsequent therapy was longer in the PARP inhibitor arm at 27 months versus 7.2 months in the placebo arm with a significant hazard ratio. It was noted that 22% of patients were still on maintenance PARP inhibitor after 5 years, showing the benefit and manageable toxicities of PARP inhibitors, but it was noted that 40% of patients dropped out in that year. Overall, there were a higher number of grade 3 adverse events in the PARP inhibitor arm at nearly 46%, and about 50% of patients had a dose interruption due to an adverse event. The most common toxicities that were seen were fatigue and GIT symptoms. In addition, 1% of patients who received a PARP inhibitor who were BRCA mutant showed evidence of a myelodysplastic syndrome or acute myeloid leukemia on follow-up. So SOLO2 is the first phase 3 study of a maintenance PARP inhibitor to report an overall survival benefit in patients that are BRCA mutated. At 5 years, over 40% of patients who were treated with a PARP inhibitor were still alive. There was few adverse events, and it was found that this was a tolerable treatment regimen. Again, for us here in Africa, unfortunately, due to the high cost of the drug and limited access, this is only available to fee-paying patients who have the income to do this. And the BRCA status of ovarian cancer patients on the continent is as yet unknown. Thank you very much for your attention.